So the first question was regarding the MIND-ACT data that you presented, Anosheh. And one of the issues, of course, is that alarming paper from the Oxford Overview that detailed the relapse pattern and second breast cancer events from the Oxford Overview from years 10 through 20. So the question, I guess, is 8-year follow-up with MIND-ACT sufficient to be comforted by not giving endocrine therapy for the ultra-low risk population?
Yeah, and I don't think so. I think we need more data. I think we need a larger prospective study. And I do agree that 8 years in this particular population is not sufficient to omit such an important adjuvant therapy that overall is fairly well tolerated.
What's actually also interesting is if you look at the 21 gene recurrence score, the oncotype data, the high recurrence score didn't seem to get much benefit from endocrine therapy. And it was really the low group, which are estrogen receptor driven, that got the benefit, yet we're not willing to do a randomized trial in the high risk group to omit endocrine therapy.
Yeah, and I have a hard time really thinking that that type of study is going to be able to be done, even in that low risk group because of that information that we already have. So yeah, I don't know that that's going to ever be an option. No, I do have some patients that are really sensitive to tamoxifen, and rather than omitting it, I'm okay with taking it every other day or taking a lower dose based on some of the studies from Europe looking at precursor lesions or high risk breast cancer patients who have not invasive cancer, but have a risk of developing breast cancer who were shown to have a benefit of a lower dose of tamoxifen. I think that will be another interesting study, in particular for those who really cannot tolerate the current 20 milligram dose. But I just don't see that idea of completely omitting it. That seems far-fetched.
Right. I would actually love to have a replicate of that Italian study that looked at 5 milligrams daily. It did appear to be better tolerated. I don't think the same is true for the aromatase inhibitors, though, because I think they're closer to, they're trying to get rid of ligand. And we've done a study here that looked at combinations of drugs, and we happen to combine it with a very significant inducer of CYP3A4. So the metabolism of the aromatase inhibitors was dramatically changed. And we dropped the AUC of the drugs by 50 to 80%. But in that trial, we also saw some patients had elevations in estrogen in their blood, estradiol, which would, of course, be completely counterproductive. So I don't actually think you can extrapolate that from tamoxifen to an aromatase inhibitor.
Yeah.
So there was another question: will you consider neoadjuvant chemotherapy for a 2.5 centimeter triple positive breast cancer, node negative, otherwise healthy young individual? I think I favor neoadjuvant therapy for almost all HER2 positive patients. I think the issue is that you can get very high rates of pathologic complete response, albeit lower in the ER positive subgroup. You can potentially decrease the need to find axillary positive nodes at the time of surgery, and therefore complicate the management of the axilla. You can also diminish some of the radiation considerations. I think the downside of neoadjuvant therapy is we have a number of successful adjuvant options. We have TCHP, we have, I suppose, still TCH, although I don't think anybody uses that, and we have TH. And perhaps also TDM1. And the TH, of course, has been used with really good 7-year outcomes in node-negative breast cancer. Now, the trial that was published by Delaney did include some T2 N0 patients. I don't personally feel comfortable treating the T2 N0 HER2 positive patients with TH alone, unless there were some physiologic reason why a reduced dose would be indicated. I think that's perhaps a stylistic issue, but that's sort of where I would draw the line with T2 rather than T1C. Anosheh?
Yeah, I agree with that. With that size of a tumor, you worry that perhaps there are some potentially lymph nodes involved too. And so if you could spare that person an axillary lymph node dissection, I think it makes a lot of sense to give chemotherapy up front.
Yeah, I mean, I have to say that our surgeons are a little bit wishy-washy on what they want to do with the axilla. In general, they're just hugely reluctant to go back in for axillary lymph node dissections. So we are usually dealing with that.
Yeah.
There was another question. So besides the olaparib data in adjuvant setting for patients with BRCA mutation, were there any practice-changing data presented at ASCO? Well, I don't know. For me, it was ESMO plenary session that I think has the answer to that one. Anosheh, you want to?
I would agree with that. And I know you should present that data because I know you attended that plenary. Yes, I would definitely agree that that is a practice-changing.
Sure. So Keynote 522 was just presented the plenary session of ESMO a couple days ago by Peter Schmidt. And basically that trial, which was sponsored by, Merck, looked at preoperative therapy for triple-negative breast cancer, T2 or greater. The chemotherapy backbone was AC for 4 cycles, followed by carboplatin Taxol. The randomization was between pembrolizumab concurrently and then in the adjuvant setting to complete a whole year of pembrolizumab. And they had previously published the 18-month event-free survival, showing a increase in pathologic complete responses from about 56% up to 69% or something in that range, and then had shown a trend in event-free survival at the 18-month mark. Most of us felt this was preliminary and should not translate to standard of care. Now they present with 39-month follow-up, and they present the 36-month event-free survival, showing an 8% absolute advantage for the pembrolizumab arm. This is very significant. So that's in the entire group. When they broke it down by the pathologic complete response versus the non-pathologic complete response patients, what was shown is that there was no evident additional benefit to pembrolizumab versus not placebo, indicating that once you hit pathologic complete response, you may not need further therapy. So it does bring into question whether a full adjuvant year is required. The second point was that the big benefit for adding the pembrolizumab were in the folks who did not get a pathologic complete response to their treatment. Now this, of course, could be then broken down, and we don't have this type of subset analysis in terms of looking at the degree of response. So there's residual tumor burden scores, residual cancer burden, RCB, that's used in I-SPY 2 and other trials. And RCB1, which basically is only microscopic disease left at time of surgery, do very well. Whether they would benefit from additional pembrolizumab is not known. The other thing that was presented was that if you had high CPS scores, you got a bigger benefit and a much higher pathologic complete response than if you didn't had low scores. But even the PD-L1 negative tumors appeared to tumors appeared to benefit from pembrolizumab. So very exciting. And I do consider that probably a game changer. Obviously, the FDA has not ruled on it, nor has NCCN and so forth, but it's likely. Now, the problem, of course, is expense.
Yeah.
So we have a couple of other questions. One is on the acupuncture. This was not my trial. I wish I were. I mean, it was a SWOG trial, and I was involved with the discussions of developing this trial. But I do use acupuncture for aromatase inhibitor achiness, and I use it for other neuropathic pain situations. It has been useful in nausea control for some individuals. In general, my impression, and correct me if you have other experience, is that if it's going to work, it usually will work within the first 3 sessions.
Yeah, and I have had really good success with it. And thankfully, we have a center that has provided access to our patients. So it's easy for them to receive this if, they have the time and, transportation. But I agree, it's a harmless practice with potential benefits. And I would say maybe 30-40% of my patients have tried it with good success.
The issue is affordability. Unfortunately, insurance, despite trials like this, have not covered it. So patients have to pay out of pocket. So that's hopefully with trials like this, insurance will start to pay for these things.
Yeah. So
can you address the next one?
Yeah, germline BRCA, ER positive, local recurrent disease. Any role of adjuvant olaparib after surgery? Local recurrent disease. So in a curative setting, I'm assuming. I mean, I think that could certainly be considered. That is a high-risk patient. And it kind of depends on the degree of recurrence. Certainly other modalities, obviously surgery, radiation, would also be in the mix. I guess the question is sort of how to sequence that with your anti-endocrine therapy. Or if you could do both at the same time, say fulvestrant, olaparib, or something like that. And we don't have data for that. I have used that in my metastatic BRCA positive patients who are hormone receptor positive. And, eventually they progress, but, you could use that, or you could start with fulvestrant and then add on a PARP inhibitor. But that is not currently something that's in the NCCN guidelines or approved in that setting, but it's something that you could consider.
Another, and I think you could extrapolate from the Calora trial. Admittedly, it's a flawed trial and everything, and just say that effective therapy should be given that reflects the biology of the tumor that recurred. And so since we have safety data with endocrine therapy plus PARP inhibitor, we should be able to give that.
Combined.
I mean, it's not that common a situation, so we're never going to.
No, and in my experience, they really haven't. The side effect profiles really are very different and overall well tolerated.
So in the next question, it's a question of if somebody progresses on endocrine therapy plus palbociclib, is it appropriate to give a different endocrine therapy plus abemaciclib? So we don't have that data yet. There are a number of randomized trials that are looking at sequential CDK4/6 inhibitors. If you look in preclinical models, however, there is cross resistance. And it's not clear, in fact, that this would be an effective thing. So I typically have not given sequential CDK4/6 inhibitors. Admittedly, abemaciclib is perhaps somewhat more potent than the other two, possibly because it's given continuously, possibly because it's slightly different. But we lack data as far as I know. And then in terms of the PI3 kinase mutation, they do have a worse prognosis if you have a mutation, but they still benefit from the CDK4/6 inhibitors. So I do give somebody with PI3 kinase mutations a CDK4/6 inhibitor in the first line setting. I think the survival data really says you need to give this pretty much to everybody, with rare exceptions, that the CDK4/6 inhibitors really are impacting long-term outcome of metastatic breast cancer. And I would give it to anybody, including people with these mutations. It's just that they have a worse prognosis. Luckily, they do have PI3 kinase inhibitors to fall back on.
Mm-hmm. So that question, are we ready to use HER2-directed therapy plus hormone therapy in adjuvant setting in early stage node-negative breast cancer and triple-positive breast cancer and skip chemotherapy? That wasn't really what the WSG ADAPT trial was addressing, because that was only in HER2-positive and then ERPR-negative breast cancer patients, and that showed a really fantastic response in that particular patient population. So I don't think that we can extrapolate that data to skip chemotherapy for this other population, if that's what that question is aiming to address. I don't know, Anthony, if you have any other thoughts on that.
Well, I think we are involved with these de-escalation trials, and they're exciting. And I think the neoadjuvant data sort of supports the hypothesis that if you get a pathologic complete response, that's all you need to get, that you don't need further therapy no matter how you get there. Now, that's a hypothesis, first of all. And it's being strengthened as we speak by further follow-up of various trials. And I think most of us think about 3-year event-free survival as one of the endpoints that we really would like to see before we come to any conclusions. The downside of de-escalating therapy is the question of whether you generate resistance in the patients who don't get a pathologic complete response. So, the way to generate cellular resistance to any given therapy in the laboratory is to give lower dose therapy. And we do have things like a really old study, I think it was CLGB 9541, which is before Anosheh was actually born. Just kidding. But basically that looked at, what was it, CMF at 2 different doses, and clearly the standard dose is superior in terms of outcome. So it does suggest that you might or might not be able to sort of recoup if you first give a lower dose or less toxic therapy, and then salvage those patients in a sense with regular therapy if they don't achieve an adequate response. But that also requires being able to look at the patient and look at the tumor response. So that's very appropriate in the neoadjuvant setting as a hypothesis, but less appropriate in the adjuvant setting when you really don't have feedback.
Yeah. And I think we only have 1 more minute. Is that correct? Or am I wrong on that one?
So tomorrow is Monday. No, tomorrow, 2 days from now is Monday. Are we going to use pre-op, IO therapy for triple negative breast cancer? As you know, we have the I-SPY 2 trial open at our institution, and most of the arms include IO therapy, but there are a couple of arms that don't. You're PI of one of the arms with IO therapy, but there's trilaciclib that doesn't have it, and there's one other arm which I'm PI of with SID985 that doesn't have it. Do all arms now need to have this for triple negative breast cancer?
Well, I think that the question is a good one, and I suspect that if I say on Monday, see a high-risk triple negative breast cancer patient who is otherwise healthy, no autoimmune conditions, and I have the option of going through the I-SPY clinical trial or proceed with a chemotherapy regimen of my choice, and she gets randomized to a non-immunotherapy regimen, I would want to talk to her about some of these new data and the potential of some practice changing standard of care options down the line, maybe in a month or 2 or longer, and then make an decision with the patient regarding to proceed with that arm versus going off of the I-SPY therapy arm and proceeding with the Keynote 522 regimen. I think if it's someone who's node negative, which is with a small tumor, I would be less of a, necessarily push for that. But certainly if someone does have more aggressive features, it wouldn't make me feel great to not at least have that conversation with them and make sure that they are aware of this new data.
Do they need the carboplatin?
I would at this point. I think it's so hard to start concocting your own regimen outside of this data. I would hope that with time we can fine tune this and have a better sense of what is really needed, and as well, of course, whether they need that whole year of adjuvant pembrolizumab is another question. But as of right now, I don't think I would omit it.
Right.
I would certainly omit it if they start having cytopenias, which often happens. So it might happen anyways.
Right. The S1418 trial just finished accrual recently, and that was preoperative chemotherapy in those patients with residual disease, got a year of pembrolizumab or not. And, that might also inform, do you need to give IO up front, or can you consider it afterwards if they turn out not to have an adequate response because of the data, for example, that was demonstrated at ESMO, that the PathCR patients didn't seem to need that. And of course, there are substantial toxicities associated with these antibodies.
Yep.
So there's another question, which is an interesting one, on somatic BRCA1/2 in olaparib trial.
Yeah, so the Olympia trial did not contain any patients with a somatic BRCA1 or 2 gene mutation. With that said, these PARP inhibitors have had approvals in other tumor types with only a somatic mutation in prostate cancer, ovarian cancer, and that was based on good data to support that. We don't currently have that in breast cancer. And I don't know that I would necessarily proceed with that in the early stage setting, but certainly in someone who has metastatic breast cancer, if you do a genomic assay and you find out that they have a somatic BRCA1/2 or PALB2 gene mutation, I would definitely discuss adding a PARP inhibitor as part of one of the regimens to consider for that patient.
And that's based on Nadine Tung's trial from the TBCRC.
Yeah, and also there was a trial out of Stanford that showed that PALB2 gene mutation carriers with either germline or somatic mutations did have a response to talazoparib single agent.
So how are you handling alpelisib? That seems a very difficult drug. How do you manage that when you're starting it?
Yeah, I haven't had too many patients on it. I feel like I have to ramp up the metformin pretty drastically and kind of continue to monitor blood sugars and then kind of maintain various other symptomatic types of drugs for mouth pain and other types of symptoms that arise. So overall, I feel like it is a hard drug to manage, but I think thankfully, if you discuss that upfront and you have a good mix of things to consider and ensure that the patient has those at home if needed, it's better tolerated. Definitely, I think keeping an eye on the blood sugars is key. And I haven't had anyone who has not needed to be on metformin. I don't know what your experience is with that.
Yeah, I mean, I routinely start metformin, and actually, I had one patient who suffered DKA, which was really severe. So I actually, at this point, am starting half dose and then taper up on a weekly dose basis, and I have all the patients getting glucose monitoring devices and monitoring at home on a daily basis. It's interesting, one patient of mine altered the timing of when she took the alpelisib relative to when she was testing glucose. And it did look to her as though if she took the alpelisib at bedtime, the morning glucose was the highest sugar. Whereas if she took it in the morning, the afternoon glucose is the highest. So it may be that it might conceivably be even safer to give it at bedtime, just because usually your lowest blood sugar for a non-diabetic is going to be in the morning, and the afternoon sugars are usually a little bit higher. Again, I don't know of any data to truly, this is totally anecdotal, but I don't have enough experience in terms of large numbers of patients. One does need to try to prophylax against the skin rash and the mouth sores.
Yeah. Yeah, it's not an easy drug, that's for sure.
Do you think capanelisib is going to be any safer or have a better out?
I don't know. I haven't really had anyone.
We just have one trial using it. I have one patient on it currently and seems to be doing well.
Yeah. So this is actually in response, I think, to what you're saying. Would you start metformin prophylactically? Absolutely.
Right. And you know, with neratinib, the data for a dose escalation is actually quite good, and that's actually been documented in a clinical trial. So if you start with half dose and then increase to 3/4 and then to full dose, the diarrhea is substantially better. And I've had some experience with that dose modification. I've actually done the same with pazopanib and other things in sarcoma, and it does seem to be much better. And the question is here, do we start metformin prophylactically? The answer is yes. And in fact, Claritin upfront as well. because the rash is an early toxicity as well. Median time to that rash is about 15 or so days. The glucose is much more immediate. And so we do prophylax for that drug. All right, there are just a few more minutes for questions. Otherwise, we're good. So thank you very much for attending. It's been a pleasure to prepare this, and I've heard a number of the other presentations, and am really happy about the quality of those presentations. Thank you for asking questions, because it's always more fun with that. There is a CME presentation on optimizing therapy in HER2-positive disease available for review. No, there's one more question. If a patient with HER2-positive and disease and brain metastasis used tucatinib earlier.
I'll have you answer that one.
What?
There's
the HER2 CLIMB trial, which looked at second and third line patients primarily. And I know that, in the NCCN revised guidelines that just came out, this was discussed ad nauseum, and basically, while overall the tucatinib, capecitabine, trastuzumab combination was felt to be third line along with TDXD, trastuzumab deruxtecan. I won't give you the entire name because it's impossible. But it's also approved for second line in the presence of brain metastasis. And so the answer is yes, tucatinib does have activity. Now, TDXD also probably has activity in the brain, as presented by, I think, one of the Destiny trials. So I think it remains to be seen, which one is better and whether the combination is better. And certainly there are trials of TDXD plus minus tucatinib and palbociclib and other combinations that are being done, because brain metastasis in the adjuvant setting is an unmet need. That's a problem.
Well, thank you.
All right. Thank you.
Yeah, thanks for having us.